Let's talk about screening for colorectal cancer. Who needs to be screened? When do you need to be screened? How often do you need to be screened? What is average risk and what's advanced risk? What's a family history of colon cancer? And most importantly, what are the different options for screening? Can you do stool tests? Can you do a CT colonography? Do you need to do a colonoscopy? We're going to go through all that today at Citizen Surgeon. Welcome back to Citizen Surgeon. My name is Dr. Erik Pearson. I'm a pediatric surgeon and I'm here to scale surgical education, get you comfortable on the wards, in the ICU, in the operating room, of course, on your exams. If you're not a doctor, I'm here to provide education, and this is an extremely important topic. We're talking about colon cancer screening, and I think this is a topic for all humans. So we're going to get through a lot of important stuff here. I'm going to provide some references in the description below. So I think whoever you are, you're going to get a ton out of it. As always, this is medical education. This isn't medical advice. So if you do have questions that pertain to your health, make sure you ask your doctor or your healthcare professional. If you have questions on the educational content, leave a comment down below and I'll get back to you. All right, let's jump into it. Colon cancer screening. This is part 2. If you didn't get a chance to watch part 1, that's where I talked all about what colon cancer is, how common it is, what the trends are, of course, risks for colon cancer, those that we can modify, those we can't. We talked about the familial syndromes of colon cancer, so Lynch syndrome, FAP, MUTH, juvenile polyposis. Any of that ring a bell? Well, if it doesn't, check out that first video. Okay, so today, colon cancer screening. And there are a bunch of options now. You know, we used to just do colonoscopy, but now there are stool tests that we can do. We can do visual tests like CT colonography. And then, of course, we can do colonoscopy, or we can do flexible sigmoidoscopy or flexible sigmoidoscopy plus a stool test. So a lot out there. We're going to get through it all today. And importantly, the things that I want you to come away with are: what are the options for screening? Who needs to be screened? When do they need to be screened? And what is the efficacy of each of these tests? So how does a stool study compare to CT colonography or a colonoscopy? Okay, so we're going to get through some of those numbers a little bit later on. Now, while I feel that this video is a video for all humans, I feel like this paper right here is a paper that all humans should be reading, especially any doctors, anybody that interacts with a patient that may need to be screened for colon cancer. You need to read this, okay? It goes through everything and it gives you the data. I'll put a link to this paper. It's freely available in the description below. And so, like we talked about, there's a lot of options. We got stool tests, we got visual tests, we got radiology, and you know, they're working on blood tests, but the blood tests that are available aren't really recommended by the Special Task Force on colon cancer screening. So we're not there yet. And the idea is that perhaps someday we will be able to detect signatures of colon cancer within the blood while they are still curable, but we're not quite there yet. All right, so we're going to talk about these other options, which is stool, whether it's radiology, and then of course visual like colonoscopy or flexible sigmoidoscopy. Now, what is one really important message that I want to drive home? Why are we talking about all of these other options? It's because there is really poor adherence to colon cancer screening. When we look at all adults that should be screened, so those are all adults over the age of 45, and then even below that, before that, if you have inflammatory bowel disease, or if you have a family history, or if you have familial cancer syndrome, we talked all about that last week. So up to a third of adults go unscreened. And this is why, or one strong reason why we still have high cancer mortality from colorectal cancer and still a high incidence. And that's why last time I talked about there's over 46,000 deaths from colorectal cancer. So if we can get screened, we can detect not only colorectal cancer early while it's more curable, we can detect precancerous lesions like those small adenomas, those large adenomas, or even carcinoma in situ. Now, there are a bunch of benefits to screening. So check this out. For every 1,000 persons screened, what do we see? Well, we see 200 to 300 years of life gained. We see 40 to 60 colon cancers averted. And we see almost 30 colorectal cancer deaths avoided. And so that's evidence right there that we need to be promoting safe screening, not only for our patients, but for ourselves and our friends and our colleagues, okay? The other message is that if we can detect curable colorectal cancer, we can decrease colorectal mortality. If we can detect precancerous lesions like adenomas, then we can decrease the incidence of colorectal cancer. But we can't decrease the incidence of colorectal cancer if we're only detecting it when it's become a cancer, okay? And we're gonna talk about that in the screening. So for instance, some screening tests like fecal occult blood or the FIT test or the sDNA FIT test or Cologaurd are really good at detecting colorectal cancer, but not so good at detecting these precancerous lesions like small adenomas and large adenomas. And the only way to decrease incidence is to identify precancerous lesions so that they can be treated before they become cancers. And we talked about that adenoma carcinoma sequence in the last video, so check that out. It is an evolution from normal healthy mucosa to small adenoma, large adenoma, carcinoma in situ, and then finally a cancer. And that takes sometimes years to go through. So the first big question, check this out, all right? So when should colorectal screening start, all right? Well, that depends. Are you average risk or are you at advanced risk? Okay, so for the average risk individual, what does it mean to be average risk? So to be average risk means you don't have a history of colorectal cancer, you don't have a history of polyps, you don't have a strong family history of colorectal cancer, you don't have inflammatory bowel disease, you don't have a hereditary cancer syndrome, and you don't have a history of radiation to the abdomen. If that is you, or if that is one of your patients or one of your friends, and that means you need to start colorectal screening at the age of 45 years old and continue until the age of 75 years old. If you're between 76 years old and 85 years old, screening is based on your personal preferences. If you feel that you're going to live much longer, then the Special Task Force recommends screening. And if you're 86 years or older, colorectal screening is not recommended at this time. So now let's talk about advanced risk, because that's where it gets a little more complicated. So what is advanced risk? Well, advanced risk is if you have a personal history of colorectal cancer. If you have a strong family history of colorectal cancer, we're going to talk about what does that even mean in a minute. If you have a personal history of inflammatory bowel disease, if you have a history of radiation to the abdomen, or if you have a hereditary cancer syndrome. So what does a strong family history of colorectal cancer mean? It means a history of a colorectal cancer or an advanced adenomatous polyp or a serrated polyp in any first-degree relative under the age of 60 years old, or two first-degree relatives at any age with one of these problems, okay? So that is a strong family history of colorectal cancer, and if your patient has that, then they go into the advanced risk category, and the timing of starting your screening is a little bit different. And what does that screening look like? Well, we start early screening, and that is starting at the age of 40 or 10 years before that earliest relative was diagnosed. So if a first-degree relative was diagnosed with a colorectal cancer or an advanced adenomatous polyp or a serrated lesion at the age of 42 years old, then when would you start the screening, or when would you recommend starting screening? Well, 10 years before that would be 32 years old. If that person was diagnosed at 52 years old, then you would start the screening at 40 years old. So I hope that's clear. How about in the incidence of inflammatory bowel disease? Well, inflammatory bowel disease, you're going to start. Well, in inflammatory bowel disease, there is an increased risk of colorectal cancer. This is for both ulcerative colitis and for Crohn's disease. And so screening for colorectal cancer begins 8 years after the diagnosis of inflammatory bowel disease. Now, this is a recommendation. Of course, this decision is made between the patient and their gastroenterologist or their colorectal surgeon. Now, one additional caveat or one additional feature is if that patient has primary sclerosing cholangitis, that is a risk factor for colorectal cancer in patients with inflammatory bowel disease. And the recommendation is they get colorectal cancer screening or surveillance every year. When we look at interval surveillance for colorectal cancer screening in patients with IBD, we're looking at 1 to 3 years. And again, that depends on the recommendation by that patient's physician, their gastroenterologist. Now, how about one of these hereditary cancer syndromes like familial adenomatous polyposis, so FAP, okay? Well, FAP leads to a huge burden of polyps, and almost 100% of these polyps will become cancerous if nothing is done about them, okay? Now, there is FAP, and there is attenuated FAP, and attenuated FAP is a version where you get fewer polyps, okay? So what are the screening recommendations? Well, initially, and this is a decision between the family and the pediatric gastroenterologist, the decision for screening will usually be at around 10 to 12 years of age. For attenuated FAP, that's a little bit later, so around 18 years of age. Once polyps are found, then interval surveillance is every 1 to 2 years until surgery is planned. And sometimes that may be a restorative proctocolectomy, so removing the colon and the rectum and doing a J-pouch, or for attenuated FAP, it might be something less. So perhaps a total abdominal colectomy with an ileorectal anastomosis if the rectum spared. It really depends on that conversation between the GI doctor and the surgeon and the family. Well, how about radiation to the abdomen? When does screening start for that? Well, for radiation to the abdomen, screening usually begins 10 years after the treatment or 35 years of age, whatever is earlier, because we want to be pretty conservative because of the risk of colorectal cancer in patients who have had a history of radiation to the abdomen. Now, we talked all about these screening options. In advanced risk, the real screening option is colonoscopy. Right now, the Special Task Force does not recommend non-colonoscopic surveillance. So that's definitely a decision that happens between the doctor and the patient on what surveillance is recommended if they are in advanced risk. But right now, the recommendation is for colonoscopy. Now, how about average risk? Now, average risk means we don't have any of those bullet points that we mentioned earlier. Okay, and so here we do have some options. We have stool tests, we have colonoscopy, okay, the gold standard, but we also have radiology, okay, so CT colonography. So what are all those tests? What are all those options? Okay, so let's do the stool test first. So the stool test, there are 3 ones to think about, and they all have the same idea, okay, and that is to check for the evidence of blood in the stool or breakdown products of blood. Okay, so fecal occult blood tests are highly sensitive. Fecal occult blood tests. Now, this has been shown to reduce mortality in colorectal cancer. Okay, and this is a test which requires 3 separate samples. It does require a change in the diet, and it needs to be done every year. If you don't change the diet, then you can have some false positives with this test, okay? But it needs to be done every year, and 3 samples are required. And that detects the presence of blood within the stool, and the blood is that signal that a colorectal cancer may be present. Well, the next one is the FIT test, and this is the fecal immunochemical test. Now, what is this? Now, the fecal immunochemical test also tests for the presence of blood in the stool, or breakdown products of blood. And how is this completed? Now, this has also been shown to reduce mortality in colorectal cancer, so it is a screening option. It also detects the presence of blood in the stool. Now, the nice thing is this doesn't require dietary restrictions. It only requires one stool sample, but it does need to be repeated every year. We've shown that fecal occult blood tests and fecal immunochemical tests, they both detect colorectal cancer, but they really don't detect precursor lesions, okay? Because for the most part, with the exception of perhaps serrated or villous adenomas, precursor lesions will not bleed, and so you don't get that detection of blood. So the DNA fit test is a little bit different, and this is also known, the trademark name would be Cologaurd. And so Cologaurd detects both blood, but also breakdown products of colorectal cancer and precancerous lesions. So you do have a little bit of that detection there. Now, Cologaurd needs to be repeated every 1 to 3 years. It's a single stool sample. So it is clear that there is a lot of interesting information coming out about this DNA fit test, or Cologaurd, and it is recommended as a screening tool every 1 to 3 years. Now, as I commented, with the stool test, there is limited detection of precancerous lesions. So stool tests will decrease mortality by detection of curable colorectal cancer, but they may not decrease the incidence of colorectal cancer because we're not detecting these precancerous lesions. Now that we understand the stool screening test, how about radiology? Well, the radiological test is called CT colonography. And what is that? Well, you go in for a CT scan, but in addition, a small catheter is placed in the rectum, gas, CO2 gas is instilled into the rectum colon, and that distends it, where a CT is done to look for not only colorectal cancer, but also these adenomas or precancerous lesions. The sensitivity for detecting colorectal cancer is 86 to 100%, and that's across 6 different studies. The detection of large adenomas, so those greater than 10 millimeters, is greater than 89% with 94% specificity. And interestingly, in 1 to about 11% of patients, some extracolonic finding is noted. Now, in those patients, less than 3% needed a medical or surgical intervention, but let's say that there was a pancreatic mass or a liver mass or some other abnormality, an ovarian mass. That could be detected by CT colonography, whereas in the other tests, whether it's a stool sample, even colonoscopy, you're only looking really at the colon and the rectum. Now, finally, let's talk about direct visualization. Now, I say direct visualization because it's not just colonoscopy. There's also flexible sigmoidoscopy. But let's talk about colonoscopy first. So, colonoscopy is a procedure. It carries with it the risks of bleeding and perforation. Those risks increase with age, but there is very high sensitivity and specificity for the detection of not only colorectal cancer, but also precancerous lesions, and that's small and large adenomas. We know that colonoscopy does reduce colorectal cancer mortality as a screening method. We also know that the sensitivity and specificity for detecting colorectal cancer is over 90%. About 70 to 85% for small adenomas, and then over 90% for large adenomas. So not only can we detect them, the small adenomas and large adenomas, but using snares and other techniques, we can excise and treat them so they don't become cancers down the line. And I think that part is really important. It's not only diagnostic, it's also therapeutic. How often should colonoscopy be done? If it is done on its own as a screening test, and that's every 10 years. Now, that might change if a polyp is found. It might change if a colorectal cancer is found, of course, okay? It might change depending on what the physician, the gastroenterologist, or the colorectal surgeon sees. So, but in general, the screening interval would be 10 years. Well, how about flexible sigmoidoscopy? Well, flexible sigmoidoscopy has been shown to reduce colorectal cancer mortality, mostly by detecting cancers in the sigmoid colon and the rectum, but it's going to miss cancers in the right colon. So how could we increase the efficacy of flexible sigmoidoscopy? Well, the paper does a really nice job, and there's other references as well, that if we do flexible sigmoidoscopy, so we look at the rectum and the sigmoid colon plus a fit test, then we can reduce colorectal cancer mortality. Now, you may be watching this in the United States, you might be watching this in another part of the world. So in that situation, perhaps there is access to flexible sigmoidoscopy. That's one of the wonderful things about the stool test, is that in places where colonoscopy is not available, a simple stool test can be sent off or even done right at point of care to see if a colonoscopy or some intervention or additional studies are needed. So flexible sigmoidoscopy on its own as a screening method every 5 years, or if it's combined with a fit, then it can be done every 10 years with an annual fit test. Now, flexible sigmoidoscopy misses those right-sided cancers, so combining it with a fit test does improve detection. So if we look at all of these tests and how often we should get them, know that the high sensitivity fecal occult blood test is every year. The fit test is every year. The DNA fit test or Cologaurd is every 1 to 3 years. When we look at radiology, so CT colonography, that's every 5 years. Colonoscopies every 10 years, flexible sigmoidoscopies every 5 years, and flexible sigmoidoscopy with a fit test is 10 years for the Flex Sig plus an annual fit test. Okay, now these are the screening recommendations by the U.S. Special Task Force for colorectal screening. But more importantly, these decisions are not just based on a paper. These decisions are made between a patient and their physician. So that is really, really important. I hope you enjoyed that talk today at Citizen Surgeon. We talked all about screening. We talked about the different options for screening. We talked about who needs to get screened and how often. We talked about average risk. We talked about advanced risk. We talked a lot about all of those things we mentioned in that first video on what colon cancer is, how common it is, and of course, what the risk factors are. So building on that first one, now we got through video 2. If you liked it, give it a like, give it a share, make sure to subscribe. That lets me know that I'm providing value. If you have any questions, leave it in the comment section. I love engaging with you. And check out CitizenSurgeon.com. I got a lot of good stuff on there, including a blog where I give my reflections on a life in surgery. All right, so as always, stay safe, study hard. I'll see you next time.